Great to have you here. Welcome, everybody. Welcome to this Q visit with Health Improvement Scotland about learning systems and human learning systems at the heart of quality management. Great to see you all here. We're just going to give it 2 minutes to allow people to join. It's a super popular visit. We've got lots of people joining today. As you're joining, if you want to introduce yourself in the chat, say hello, who you are, where you're dialing in from. You're very welcome to do that. We will do some proper intros in a little while. So while we let the main wave of people in, feel free to introduce yourselves in the chat, where you're dialing in from this morning. Welcome everyone who's just joining. We will start fairly promptly, so we will start in about 1 minute. But if you want to introduce yourselves, say where you're joining in from in the chat, please feel free to do that. Welcome everyone who's just joining for this Q visit. Learning systems at the heart of quality management with Health Improvement Scotland. We will start very shortly. If you would like to introduce yourself in the chat, please do. We've got a lovely mixture of places where people are joining from. It's great to see you all here. I'm really enjoying everyone's backgrounds as well. Some lovely places, some of which we're going to hear more about, I think. Okay, we have more people joining, and I'm sure we'll have even more because we have had a huge amount of interest in this visit. But I'm going to start us off because we also have lots of great content to take you through today. So I'm Vicky Purwell. Welcome, everyone. I am from the Visits Collective, and myself and Gweno Edwards, who Gweno, do you want to give a wave? We're going to
Hello,
be
good morning.
We're going to be looking after you this morning, and we'll introduce our hosts in a moment. We have been running Q visits for the last just over 2 years, and we have Katie Young here as well from the Health Foundation. Katie's giving a wave as well, and I'm going to introduce Katie to tell you a bit more about Q in a moment. And then the super important people that I need to introduce you to are the Health Improvement Scotland team, and we want to give a massive welcome and warm thank you to them for hosting today. I'm really excited for this visit. I know lots of you are. We've had a huge amount of interest in this visit. So they're going to introduce themselves soon, but I wanted to just welcome and maybe you give a wave to Michael, Diana, Claire, Joe. These are the people you're going to be hearing from today, and also David, and I'm not sure if Elizabeth's on. A huge thank you to you as well, who have been making this visit happen today. Oh, hi, Elizabeth. I just saw you wave. Huge thank you to agreeing to be a host for a Q visit. We're super excited. And I am going to share my screen and take you through the agenda for today. So bear with me 1 second while I line that up. My screen. Here we go. So I will just take you through the agenda for today. We are going to, in a moment, after we've heard from Katie, give you an opportunity to say hello to each other, human to human. This is about human learning systems. We want to give you a chance to say hello to each other in some small groups and do some deeper introductions. And then we have got some great presentations from the team. We've got, you'll hear from three of the team before you get a chance to reflect and discuss, think about what you've heard and what that means to you in some small groups. We'll come back for some Q&A. Oops, sorry. And then we're going to have a bit of a screen break. So you can have a comfort break, grab a cup of tea, have a stretch. Then we'll come back and hear one more presentation and again have some more time to discuss and reflect in small groups, and then come back together for some final reflections, including some key takeaways from Diana and Joe. And we'll close, and we'll be closing at 12:30. So that is the agenda for today. Katie, can I hand over to you, please, to tell us a little bit more about Q?
Yes, absolutely. Hello, everyone. I'm Katie, Q's Learning and Development Manager. It's so exciting to see so many people here today. It's such an important topic. So yeah, really big welcome and a big thank you in advance to our hosts. I know there are some non-Q members here, so I just thought I'd quickly take the opportunity to plug Q membership. If you've not already heard about Q, then we're a community of over 6,000 who are all working in or interested in improvement. The community is dedicated to driving positive change through connecting and collaborating with others who are also working and carrying out improvement work. So sharing ideas and methodologies and new approaches, all to benefit your individual work, your organisation's aims and systemic change. Members tell us they love accessing our free events like visits like this, and networking, our learning resources, and all the collaborating opportunities we have. So you can join for free. And if you'd like to know more, then please follow the link at the bottom of that slide. And on the next slide, there's a QR code as well, if that makes things easier. But yeah, we have all sorts of webinars and workshops and toolkits, as well as an extensive range of online groups. And they're a brilliant opportunity for you to connect with peers. So yeah, to access more of these fantastic learning opportunities like this brilliant visit, then please do sign up to be a member, because we'd love to have you join us. Thank you.
Lovely. Thank you, Katie. Oops, sorry. And there is a QR code that we can share again later and as a follow-up in case you want to join. So I'm going to stop sharing my screen now. And we are going to give you an opportunity to say hello to each other in some very small groups. We are going to give you about 7 or 8 minutes till about 10:15, so you've got time to say a proper hello. And we wanted to invite you to introduce yourselves, where you're from, your organisation, your role, and we wanted to invite you to share some thoughts on what quality means to you. So that's our kind of prompt question for you in your introductions. What does quality mean to you? And Gwenno, are we ready with breakout rooms? I know we've got kind of people joining all the time, so it's a bit tricky.
It's great. We've got some people joining just now. And for anyone who has just joined in the last few seconds, this is our moment to connect with other people who are here before we move into some of the presentations. And Vicky, could you just remind everyone of the question that people are going to discuss in their breakouts?
I can. I'll put it in the chat as well.
Amazing.
So the prompt question we're inviting you to share thoughts on is, what does quality mean to you?
And how long do you reckon we're going to have in these rooms?
About 7 minutes.
7 minutes. Okay, so I'm going to open up those rooms now, and hopefully you'll see a message pop up on your screen inviting you to join the room. If that pops up, please click join, and if it doesn't, we'll sort that out manually for you in a second. So enjoy your conversations. And there's a few people who have just joined, so I will make sure no one is in a room on their own.
Thanks, Gwen. Oh, Fergal, sorry about that.
Can you hear us?
Can.
We got kicked out of our room.
Oh, which room were you in?
Room 20.
We've got the same in one of the room 10 as well.
So there are ghosts of you in the room. I don't know if on your toolbar you can see a little symbol that's like a window. It might be next to a button called More. If you click on that, does it say room 20 join? Is there an option? Yes, I think they've gone. And the same for anyone else who hasn't been able to join a room. On your bottom toolbar, are you seeing a symbol that looks a bit like a window, 4 squares, or a button that says More? If you click on that, there might be the option to join room. Sweet.
Great. Thanks, Gwen.
And that is my only trick. So hopefully that works.
Welcome to anyone who's just joining. We've put people in some breakout rooms to introduce themselves to each other. If you would like to join a room, do you want to kind of raise a hand? People are going to be in there for about another 4 minutes. Fergal, you look like you're still struggling. And Yvonne, Gwenna, could we put Yvonne in a room, please? Oh, Fergal has managed to join a room. That's great. And Alison.
And yeah, if you're not seeing a square symbol in the bottom toolbar or a button that says More, and then clicking on that and saying join room, I'm afraid I'm out of tricks and this can be your breakout room.
I was about to say, perhaps anyone who is in this room who wants to say hello and introduce yourself, maybe we can do that in this room. So Alison and Tony, do you want to come off mute and say hello?
Good morning.
I'll in case I forget. Okay, we'll bring everyone back now.
And welcome everyone who's joined in the last few minutes. We've got people joining us back from breakout rooms in a moment.
Welcome back, everyone. We should have people back now.
Right. Welcome back, everybody from your breakout rooms. And if I could just ask you, if you're not on, put yourselves on mute, ready for us to start our presentations from Healthcare Improvement Scotland. First of all, I'm going to invite Michael to start the presentations. So, Michael.
Thank you very much, Vicky. So welcome everyone. My name is Michael Canavan. I thought it'd be good to start off just giving you a wee sense of place. So my name is Michael Canavan. I live in Ayrshire in Scotland. You can see behind me there, I'm standing in a small stream in amongst the hills and the mountains. I love getting outdoors. I love getting in amongst the mountains. I live in the west coast of Scotland, and just across the waters there's the Isle of Arran, and this is Glen Rosa in the Isle of Arran, and I had a great wee day to myself wandering through the hills last August or September. And there'll be a wee theme throughout the rest of the sessions introducing you to different parts of Scotland. So welcome. I'd like to extend a really warm welcome to all of you to our Healthcare Improvement Scotland virtual visit. So I lead the QMS portfolio within Healthcare Improvement Scotland. You may have had the opportunity to watch the video from our Chief Executive, Robbie Pearson. Robbie highlighted our national role in supporting health and care across Scotland and our strategic commitment to embedding QMS both in our own organisation and across NHS Scotland. And our visit today is about learning system at the heart of quality management. I haven't yet requested control, despite the fact that I've kicked us off, so I'll do that now, and I'll move the slides on. So we've done all that already. So having talked a wee bit about our commitment to embedding QMS across Scotland, this is our quality management system framework, which we published way back in 2019. Some of you may have seen our framework. Some of you may have seen other frameworks from the East London Foundation Trust or NHS Wales. There are many out there. We don't say that our QMS framework is the only way to do quality management. We see it as a framework that can help you to think about how you might consistently apply quality management. And you can see that it incorporates Duran's trilogy right at the centre, Duran's trilogy of quality control, which we prefer to call maintaining quality, trying to make the language a bit more accessible, quality planning and quality improvement. And as you can see, with a learning system right at the heart of that. So we recognised some time ago that despite a lot of effort to build capacity for quality improvement across Scotland, we were still seeing examples where the standards fell below that which we'd be expecting to see. And therefore we thought, what more is required to help us manage quality better? So we set about developing a framework to help with that. And what we heard consistently when we were working with partners and a whole range of focus groups was the importance of learning at the heart of quality management. So this idea of a learning system at the centre of quality management was, as I say, we heard loud and clear from a number of focus groups that it was really, really important to ensure that we were taking the time to intentionally learn about what we were doing. So it is the central point of our quality management system framework, and that's what today's session is all about. However, having heard that it was important, we probably found that the most difficult aspect of our framework to describe and help people understand. So it was difficult to articulate that. So we actually took some time a couple of years back to describe what we mean and to think about the core components of a learning system. So we've described it as a learning system enables a group of people to come together, to share and learn about a particular topic, to build knowledge, and to accelerate improvement and outcomes. And we're thinking more and more about the importance of that knowledge mobilization. So what are we learning and what can we share much more widely? And we also thought about, well, how do we do this? What are the practical approaches to doing this? So we think that a learning system should support individuals to learn through its culture and networks. And I'm fairly sure that a high percentage of you on the call today will be interested and involved and engaged on a daily basis around quality improvement. And you'll understand the importance of relationships and improvement. So we see a learning system and the relationships within that learning system as being really, really crucial and really important. It should be informed by evaluation and reflective practice. So taking time to think about what we're learning, to learn about what's working, to learn about what's not working, and to think about what we can be doing differently. And we do that through the use of data, insight, stories, intelligence, information. So how do we gather all of that intelligence information to start to make sense of it, to help us make the right decisions and think about next steps? So it really is about turning that knowledge into action and building systems to identify bright spots, what's working well, how can we maybe scale up and spread examples of good work into generalizable learning and more scalable practice. So not only did we describe what we meant by learning systems, and I'm sure some of you may have Googled what is a learning system. I certainly have done several times, and when you go and do that, you will find a depth and breadth of what a learning system might look like. But we decided we would also take some time to think about, well, how do you implement a learning system? And we came up with this model here. So the importance of thinking about the infrastructure. So who do you need? How are you going to do it? What are the logistics around bringing people together? And before you even start to think about learning, taking some time to think about what's the purpose? What's the specific purpose around this aspect of learning? Who do you need to be involved and how are you going to involve them? And crucially, if we're going to learn about different aspects of healthcare, I think it's really important that we think carefully about what are the inequalities that are relevant here and how might we use that learning to tackle some of those inequalities. And then the dynamic process involved is, as you can see in that Celtic knot, so bringing the people together to network, gathering the range of insights, information, intelligence, and in data, and starting to make sense of that. And then once you've made sense of that, thinking then about how do you then turn that knowledge into action and mobilize that knowledge so that it's accessible for the majority of people. And we see that we've depicted that in a Celtic knot, almost to kind of help people understand that that's a constantly evolving process. It's not a step-by-step process. We might make some sense, we might gather insights, start to make sense and think, we don't have enough information. We need to go and find out more information. So it's a dynamic process, always shifting, certainly not a linear process. And then what we thought also was the importance of evaluating from the outset to make sure that we're taking the time to really understand what are we learning and how are we using that learning and are we using it to best effect? So taking the time to think about how we evaluate that as part of that process. So that's our framework for a learning system within the quality management system. And shortly, Diana and Joe will tell you a bit more about how they've applied that in different contexts. But first, I'm going to hand over to Claire Morrison, who's going to take some time to introduce you to a new Scottish approach to change. So I'm going to hand over now to Claire. Thank you, Claire.
Brilliant, thank you ever so much. And I'm afraid I have got a really boring background after your excellent introduction. I will search for a better one. But my name's Claire Morrison. I'm Director of Engagement and Change at Healthcare Improvement Scotland. I have lived in the Scottish Highlands, just celebrated 20 years here after meeting my husband in London, and he took me to his home in the very far north of Scotland, and it was the best thing I ever did. So I will find you a better background with a good picture for later. So if we could go to the next slide, please. The initial starting point for the work on the Scottish approach to change came from NHS reform, now called NHS renewal in Scotland. And as part of the planning for NHS renewal, Scottish Government identified the need to underpin the renewal with a clear and coherent method for change. And so they commissioned us at Healthcare Improvement Scotland as the National Improvement Agency to define that approach. And I think we were really keen to take on the commission because we know, and I'm sure all of you know as well, that change isn't always done well. And that can be for a whole different variety of reasons. It could be that a structured approach isn't taken. It could be that the wrong tool is picked for the particular circumstance. It could be that there's confusion about what method to use. And all of these different problems can result in having to redo work at a later point. And at this time, thinking about NHS reform and renewal, clearly we don't have time for that. If we can go on to the next slide, please. Thank you. So I think before we started this work, we reflected that to make the Scottish approach to change really work, it needed to be across the whole health and social care system rather than just simply focusing on the NHS renewal aspect. But to be clear, what we are not doing is creating a new change method. We absolutely recognise there are multiple methods or disciplines of change that exist already, whether that's quality improvement, whether it's service design, engagement practice, or strategic planning. All of these elements, they're vital and useful in change, and we know they work. We don't need to invent something new, but we have got two problems with what we have at the moment. And the first is that people can be expert in a single discipline, so they may not be able to draw on that full breadth of the different methods that are available for any particular situation. And in some cases, teams that use the different disciplines might work entirely separately from each other. And then the second problem is that for many people in the health and care system who are currently leading change, these methods can be theories they've studied in detail, but not systematically applied in real life. And so these problems mean there is a barrier for the health and care system to really maximise the benefits of all of these different change disciplines in practice. And so that's what we're trying to do with the Scottish approach to change is we're trying to move from the theory into the practical, from multiple methods to a clear and systematic approach that defines how to bring all these methods together and provide a guide for people who are leading change. Can we go on to the next slide, please? So importantly, the Scottish approach to change doesn't undermine, and I think we would say it actively embraces the individual methods. So here we have service design and strategic planning and quality improvement and engagement. And it's bringing them all together coherently and effectively to deliver change. And I think this is the real strength of the Scottish approach to change. So for those of us who are experienced in delivering change, I think it will feel naturally aligned to what our instincts are in terms of how we would approach change. I just want to stress a couple of other aims of the work. So I've said already, it's about supporting people in a practical way about how to do change. And linked to this is around accessibility. So it has to be accessible to people with different levels of knowledge. There is absolutely no point in creating something that only a tiny percentage of people can understand. It has to make sense for everyone, from those who have a basic awareness of change through to really experienced change leaders. And I can certainly remember feeling excluded from the Quality Improvement Club before I studied improvement. And I still find that sad, because the best outcome surely is to enable everybody to make improvement in health and care. And so this means we need to create a simple and universal language for the Scottish approach to change. We want it to be jointly understood and jointly owned by everyone, not something that's owned by us at Healthcare Improvement Scotland or defined by any specific terminology. We want it to belong to everyone, and so that we can normalise change being done well. Next slide, please. So the first step has been to develop a high-level framework for change. And the reason we did this was to enable us to engage with stakeholders widely to develop the detail. I cannot stress enough, this is in no way the finished article. It is a brief outline. It's already being changed as we're hearing from stakeholders, and that work will continue as we move through the testing period of the months ahead. But we needed to start somewhere, and this is our starting place. So to orientate what you're seeing on the screen, the left-hand side is the current state. So that's before the change takes place and where the need for change is identified. In the middle is the change cycle. And then on the right-hand side is the future state after the change has happened and it's being sustained. You'll see here the absolute clear link with the quality management system. And this is because the Scottish approach to change isn't something separate. It is completely aligned. So what the approach to change is providing is the detail of how to deliver change within the quality management system. And then the other bit to point out is underneath the change cycle, it's underpinned by 8 essentials of change, all of which need to be in place for successful change to happen. On the next slide, please. We're focusing in on this slide on the practical steps of the change cycle. So what we're currently doing is developing the detail on this. So the final tool we will produce will support people with the professional decision making within change. So what you do at every step, what you need to consider, who needs to be involved, how to do it, and all of that will be different depending on the type and the scale of the change that you're working on. So just to briefly go around the steps, at the top is the understand step, and understand is in 2 parts, both the need for change and the context in which change is happening. So this is quality planning stage, and it involves engaging with people, really importantly, and using tools like journey mapping and process mapping. Moving around to step 2, which is the development designing of the change. So this is about a clear direction of travel, defining what the change is trying to achieve and how it will happen. So this is co-designing approaches with people through tools like options appraisals, and really importantly, using equality impact assessments. Next is step 3, which is prototyping and testing the change, understanding what works and what doesn't, and continually improving and refining ideas, so using data to understand what's achieved. Step 4 is to review and implement. So this is really a formal review point after the testing phase, and to make a decision on whether to progress with the change or whether to abandon it or to move backwards and do some further work at one of the earlier stages. Next is defining and implementing the output from the change process. So what the new model is, how it works, what the resources are needed to make it work. So things like management and governance arrangements and learning and development. And then the final step within the change cycle is to embed the change. So that's moving into business as usual, having a clear implementation plan that integrates the change into the wider system. What I'm not going to talk about now is the essentials of change that underpin this change cycle, but instead I'm going to hand over to Diana, who is going to take us on a slightly longer expanded version of the journey that we've taken to create the essentials for change.
Thanks, Claire. So I'm Diana Heckram. I'm the Associate Director of Transformational Change, and we've jumped on a wee slide there. Hopefully it'll go back. I'm the Associate Director for Transformational Change at Healthcare Improvement Scotland. And I am based in Larbert, which is very near, only about 5 minutes away from the Kelpies. So I will also introduce you to Baron and Duke, who are behind me. And they are symbolic of the kind of strength that each Kelpie has the power of 10 horses, and symbolise the strength needed for the transformation in the Scottish Industrial Revolution as they pulled the canal boats along the Forth and Clyde Canal, and I think sort of symbolising the strength that we need to take us for the transformation we need in NHS renewal in Scotland, but I think in general and across health and social care in these particularly challenging times that we face. When we were originally asked to do a Q visit, there was a request from members of Q to understand about what we've done in Scotland around human learning systems approaches. And very much that human learning system approach is part of our Scottish approach to change. We've reflected with that learning into our overall and the learning that we already had around quality management systems and these variety of improvement approaches that Claire has spoken to. Why it resonated with me when I first met Toby a few years ago, 5 or 6 years ago now, was I'd spent a lot of my career working in the third sector and being commissioned in areas around palliative care and international development. And what you're dealing with is people whose lives are really complex, what their needs are multifaceted. And palliative care often say that what people needed was they needed their pain medication and they needed their dogs walked, and they were equally of important to them. So understanding what good looked like for people is really complex. But what the system wanted to do was time and task me on the number of widgets I had delivered. And when we were doing reshaping care for older people, which said 10 years ago, if we don't radically transform how we do health and social care, our hospital systems will be completely overwhelmed and our doctors will all be burnt out. And go figure, that's where we are now. If you flip that forward 10 years, I think we may end up with no hospitals and no doctors, and a primary care system that's struggling completely. Is that what they learnt from me in doing that reshaping care for older people, where we built whole system services around individuals, was how many occupied bed days we'd saved, which was a fantasy number I made up based on some random math, because how could you possibly know the answer to that question about how many occupied bed days did one service that worked alongside district nurses and primary care teams and were about that family and that individual and supported, and equally not having a direct line to the Grim Reaper to know how long people's lives would have been in the counterfactual. So that not working for the system, because they did not get the learning from all the organisations who were supporting reshaping care for older people, and they did not make the system change on the back of it, because they lived in that box of A to B when it was all far more messy than that. And why is it all far more messy than that? Is because if you take this map, this is, many of you have seen this, this is an obesity map. So it was lots of people working in public health locked in a room together for a very long time. And they mapped all the causes of obesity. And if you can see in that blue box, the health and care treatment options are a very small part of that. But organisations working in health and social care are often targeted as if they are the totality of that. And they are often expected to prove that they are delivering the outcome of that reduction in obesity. And what the human learning systems came from was a sense that there was organisations who were experiencing the same thing that I was at Marie Curie, with this slightly weird and unhelpful, not quality management system approach to managing our the £6 million of Marie Curie services in Scotland. But they were doing it right across the board. This was a ubiquitous experience. And actually, there was then a sense of, what do we need to do quality management differently that recognises this this level of complexity at individual level. And what it talks about was that at a person level, so when working with Bob in the hospital who wanted to come home to die, what did we learn and understand about Bob? What was needed to make that work? And what was needed for Bob and many other Bobs was a reduction in anxiety about the family being able to support that person who was coming home with far more demands, beds, commodes, medication systems. And they needed more time with somebody who could sit down and talk them through that and help them to look after their loved ones at home. That created at team level a change that said, actually recognising that people need some dedicated time over 4 or 5 days when they discharge somebody home to die who is more complex, that needs a bit more of that intensive support, that can get people home. That should have created at organisation and police level a greater understanding about the resilience on community, the need to support unpaid carers, the need to see services out with a direct clinical intervention, that what mattered to people was more important than that. That learning never happened because the only thing that went between team and organisation was a number of occupied bed days. And this idea that we can change that by layering our quality management systems with that learning, the rigor of the learning going from the person to the team, to the organisation and to the country. And in Scotland, we can do that. We can do frontline to minister. And we have been doing it around things like adults with incapacity recently. When you work in this way, what it takes something like human learning systems, which is in the Realistic Medicine report, page 10, for those who are interested and in Scotland. And what they did was they took a diabetes service, a pre-diabetes service that was having really poor outcomes and wasn't having the population impact they wanted, recognising that the majority of people who were at risk of pre-diabetes were from low socioeconomic backgrounds, and they found barriers to accessing and engaging with the services, and they also were only dealing and could only deal with the way the service was set up with the individual on an appointment basis. They moved the service to a community hub where there was a food bank, and met people there, and they met them, and they met their families, and they supported that person for what was going on for them, and they have now significantly reduced the amount of clinical input. They have reduced the waiting list. They have increased the number of people that they are seeing, and they've improved the outcomes for those individuals. So an all-round win, but that started with that learning about what mattered to people and understanding that at a team and organisation. The second is about one we did. North Lanarkshire had a service around in its A&E where it identified that there are people who were coming frequently into A&E. They weren't coming in for accidents or emergencies. They were coming in because it was the only place to which they could find support for a lot of unmet complex needs like addiction, poor housing, being cold, trauma. What they built, instead of just continuing to replicate that, they took it into a whole approach into their communities, and now have these community enablement hubs where people are met as whole people, across that siloed, across many previously siloed services, and are able to connect. And you can see what that has done to the community assessment waiting list. Just in that short period of time, the two peaks in that are the setup of new hubs that are bringing those waiting lists right down. But this isn't just, within our human learning systems experiments. It actually resonated with learning that we were having in our approach to change already. So this is our early intervention psychosis improvement programme. And I know there's some people from Tayside, so this is up in Tayside in Scotland. And that model, which is an evidence-based model that recognises that family interventions, CBT, medicines, and career conversations are an equal and holistic part of supporting somebody from those flags of a psychosis, of becoming psychotic, to being somebody who's back into employment and education, and supporting people to reduce addictive substances and reducing the episodes of psychosis within that population. And what that has taken to do that is that learning around the individual, and then a team and an organisation that is building that learning up right at the heart of its quality management. So it puts it into its quality planning. It puts it into how it improves and develops services, and that connection through. So when we then applied this learning and did a piece of reflective practice across many of our Healthcare Improvement Scotland change programmes over the last 10 years, and triangulated that with experience from other people who'd been trying to work in a similar way, we came up with 7 nodes of change. We've then taken those 7 nodes and we've put them into the Scottish approach to change and reflected them with a much wider, again, community, which is what's taken us to the essentials of change that Claire references. The important light bulb moment I had when we were doing this work and doing that reflective practice and our own learning was that it's about internal consistency between these things. So the person-centered approach is not a start here and end here arrow. It's supposed to give you a sense of it goes through everything. You need to have the consistency of a person-centered approach against these areas. I'm famous for saying the good stuff's in the dull stuff. I'm an economist, not a clinician. And actually, culture is not something that sits weirdly and off over the side. Culture is something that is really embedded in the way we do a lot of our dull things, in how we do our governance and finance and how we do our data measurement. So within the Scottish approach to change, what we recognised is taking that learning from our programmes and from human learning systems work was to say, what's the from and to? How do we do this in a way that recognises that we're not running factories, that we are running complex person-centred? And in our breakout earlier, an improvement advisor in Scotland reflected that difference between, even across levels of autonomy, from an acute system, which is highly state-driven, to a community system, which is fully autonomous. But people are moving and interacting with them all simultaneously. So when we do governance and finance, and including in that how we commission the third sector, are we doing it in whole system ways? Are we doing it in ways that is taking the learning about what is being effective from our frontline teams and thinking about that, what that means at a board level or an HSCP level, a sort of health and social care partnership level? Are we doing our data and measurement in ways that looks at widgets in silos, only looks at quantitative data, doesn't understand what matters, the experience of people, but equally doesn't become curious to the data it should look at once it's understood what's going on with people? I often think that the challenge is we often do data in healthcare as if it's a monopoly that you follow one step after the other, as opposed to when you are doing change, it is far more like doing Cluedo. Like you find out things and then you go and then you decide what other data and intelligence you need. Where do you need to go next on the board? What more do you need to find out? Rather than assuming it's always the same thing. And the power that rests within the existing status quo on that data and measurement, when you become curious to what matters to people, and start looking at different data and measurement, you can shift the system to these person-centred ways. Within the Scottish Approach to Change, the methods and tools that Claire spoke about, they're much more that whole system. They push us into discovery. They push us not into making assumptions. They push us into looking about where the inequalities show up. And that's a lot of our healthcare system is undeniably designed around privilege. And when you use methods and tools that break that bias towards privilege, you come up with systems that actually meet the needs of those people who need and use the system to a much greater degree. That engagement is moving away from a previously tokenistic one-off, I'm doing a consultation, here's my consultation paper, tell me what you think about the stuff I already know, to an ongoing and meaningful engagement throughout the process of change, one that recognises that people's experience is an equal discussion with people who are delivering services and that system data. So that engagement being a really meaningful and ongoing throughout everything. So when you take these alongside the collaborative leadership, which is written much about, and the learning approach that we've had Michael talk a great deal about, but that learning is that full curiosity at all levels of the system. That is where that consistency between them, that's what really struck us as being where we get held back, and why the evidence base about more preventative community models of care gets stuck, because one of these is dealt with in a way that still does a command and control widget based approach. So that's how we've taken that practical learnings, engaging with a wider human learning system community, and taken it into the totality of our learning and now into our Scottish approach to change. So I think I will now hand back to the Q team to take us into breakout groups.
Brilliant. Thank you so much, Diana. That was fantastic. And we are now, as Diana just said, going to give you all a chance to have to get curious and to reflect together. We're going to put you in groups of about 4 or 5. And we are going to give you 2 prompt questions. I've just put in the chat. What are your reflections on what you've heard so far? And what examples are happening in your context, and give you a chance to share those and reflect together. I'm going to give you a good amount of time, about 20 minutes in breakout rooms. We've had a few people coming and going, and I've just already spotted that I've got a room now that only has 2 people in it. So I'm going to rapidly move those people into other rooms, so you're not stuck in a tiny room. If anybody ends up on their own, we will try and kind of keep an eye out and move you between rooms. So if it looks like nobody's joining, you might get kind of jumped into another room. It might be that a few people aren't able to join, or for some reason can't join a room, and you would rather stay in the main room and have some quiet time on your own. Caroline, that's absolutely fine. You may want to just spend some time reflecting on and contemplating those questions yourself. So if anybody else is in that position, feel free to stay in the main room and take your camera off and spend some time thinking about those questions. So what's your reflections on what you've heard, and what examples are happening in your context? So I'm going to put you in breakout rooms now. And yeah, as I said, if you need to be moved around, just ask us and we will help you. And Linda, absolutely fine. Yes, listen. So I'm going to put you in breakout rooms now, and good luck and enjoy the conversations, and we'll see you in about 15 minutes. So, Brennan. People just joining now. Welcome back, everyone. I hope your conversations were good. If you want to share anything from your conversations, any highlights for you, please feel free to do so in the chat. We're not going to go round all of the rooms or anything. So if there's anything that stuck out for you that you'd like to share, please do share. What we are going to do now is go into a Q&A. So I have just highlighted the team who you have heard from so far, and Joe, who you will hear from in case you want to come in, Joe, on any of the questions. So we've got a little bit of time now until 25 past, so to have a Q&A. So if anybody has any questions, do raise a hand or add something in the chat. I know there were some questions earlier in the chat. There was a question about change versus improvement, and I know Claire, you answered that. I don't know if you want to add anything verbally to that, the kind of the language of change versus improvement.
Yeah, sure. So, I mean, I think I tried to summarize it in the chat. What we're trying to do is be inclusive of all of the different change methodologies, and that meant that we needed to be really careful with our language, and not make it anything that could be suggestive of being linked with any one method. So we're using change as a broad term which encompasses all of the different approaches. So it's about being inclusive and about this meaning something to everyone, no matter what their potential specialty might be in. Because if it's in service design, for example, then the language of change is as meaningful as it is for someone whose specialty and training has come from an improvement background.
There was another question that I'm not sure if it was answered from Jessica about PSIRF. Jessica, I don't know if you're still here and you want to ask that.
Hello, hi, I'm here. Sorry, I think it was more just of a comment that just listening to you, it just feels like there's quite a lot of parallels with PSIRF, which is in England is our patient safety incident response framework, which is very much about how does learning sort of translate into change and improvement. And I'm just really we're quite enthused to see, like, obviously you're making it work in a slightly different way, and sort of where we can learn from that to support the implementation of PSIRF as well in the future.
Yeah, and I think it's really important we learn from each other, isn't it? So what you're learning, what can we learn from you to take into what we're doing? So be really keen to that. I saw Joe nodding a lot, so I don't know if you want to come in on that as well.
I absolutely support that. Whilst we do not have PSIRF in Scotland, we have other mechanisms of a similar approach. And I'll come on to talk about some of the safety work shortly. But I think there is mutual opportunities for learning across our systems. And Q is a great example of how we can do that.
And Joe, and there's another comment on the chat. One of the rooms by No Design from us had 3 nations represented, so they had an opportunity to look at the variation in national levels. So I'm sure that must have been really interesting chat, and I hope that there was some useful learning. Nikki Davey in the chat has asked about some methods labeled as change are not robust. So how will people know this if they haven't had any training? I don't know if any of you want to come in on that.
Sorry, I have to admit, because I'm in the browser version of Zoom, I can't track between the questions, so I can't quite see what the question was. But I think one of the things that we're really trying to do in terms of the tool, the end tool, so we're in a development phase with this, we're in the early stages, and as we go through the full development of this, we hope that what we provide people with is a tool that will enable them to and support them to make those decisions, so that they can pick the robust tools for change that will support them through the process.
And Diana, I think you wanted to come in on that.
Yeah, I mean, because I absolutely recognise that. So where a tool like Lean can be really helpful in a process efficiency, when you're trying to think about a whole system and complexity, it doesn't work. And I've experienced where, you know, where every problem is a nail and therefore every solution is a hammer problem, where it really caused problems for a system that didn't recognise that complexity with people. As Claire said, what we benefit from in Scotland is having within Healthcare Improvement Scotland and with our partners is a broad range of experience, a really broad range of experience of doing the work of change, from patient safety programs to work that the Care Inspectorate does, and it's following its inspections and as part of its quality process, to the kind of work that we were describing in our human learning systems type of work, which is community-based, community-orientated type of work. And across all of that, what we are building is that understanding about what is the right tool for the right point, for the right problem, for the right question. And that's why in building the Scottish Approach to Change as an online resource, that while it's just, at the minute it's just a massive library, what hopefully we're going to put within it is the librarian, the person, the kind of virtual person who will say that if this is the kind of problem you're dealing with, this is probably the stage at your journey of that, and these are the kind of tools that might help you. We do also have a robust quality assurance process around everything that we will put on, so that we are both that guidance that will support people will be published and be fully transparent, but also the tools that we use are ones that we know that are validated by their, within their communities as helping, and how they, and specifically like how they can help and what level of experience you might need to be able to use them in an ethical way.
Thank you, Diana. Matthew, do you want to come off mute and add your question or comment?
I think Diana was actually answering it, because I suppose I was just saying, is there going to be some kind of tool like Dave Snowden's Cynefin model, which helps you to decide whether the problem, is a complicated one that needs best practices and blah, 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 and that kind of thing? Or is it a very complex one that maybe needs experiments and safe to fail experiments and things like that? But I think Diana was saying, well, there'll be a sort of librarian and related things that are going to emerge soon that will somehow do that, which sounds tantalizing, if not totally convincing. But
so it sounds tantalizing, if not totally convincing to us too. No, so fortunately we've got brilliant people involved in the team who do understand how to do some tech to make it possible. We recognise, and it relates to one of the other questions above. We have test sites to do this with us. So we've got all the knowledge that we're currently doing. We have all our current improvement programs. We've got engagement with other national bodies doing improvement work, improvement and change work. And then we are going to work intensively with 2 health boards in Scotland, and in an associated way with a variety of other ones, to build that understanding. So as we build the kind of that guidance, that advice into the tool that we're creating, it'll be done through real reflective practice with the work of change, and then to try and transparently build those rules. Now, the next version of the Scottish Approach to Change that come out won't have that yet. It is work that's probably going to take us to December to get another first cut out that will be the first time you'll see that virtual librarian come out towards the end of the year. But if we can do it, and it is, I can see on paper that it's doable, and I think we have the will and the experience to be able to achieve it, then it could be quite awesome.
Thank you, Diana. Michael, did you want to come in then as well?
Thank you, Vicky. So I stuck my hand up by accident, but I was waiting for the opportunity, so it's completely unrelated, but I picked up on a question from Yvonne Morgan that I don't think we've addressed yet, and it was about, is the approach to change the change management structure for if changes need to be made to your QMS, including for staff and aligning with any QMS changes. And I found that question quite interesting, actually. So I think our Scottish approach to change is hopefully being designed to help anyone who's identified any need for change to think about the right approach to addressing that change. But it made me reflect, this question in particular interesting because it made me reflect on some work that we've been doing in Healthcare Improvement Scotland, where we have very recently started to apply a quality management approach to the work that we do to support services across Scotland in perinatal. And I think I would probably acknowledge that within our own approach to QMS for perinatal services, I would say there's maybe a wee bit of a gap around robust planning to help us as an organisation think about how we can better support the system. So if we think there's a gap in how we plan our support for the system, then we need to think about how we can maybe change that approach and think about how we can start to design and test new ideas. So I think it's for any change that we identify as necessary, and I think it can be applied in changes to our own quality management approach.
Great, thank you, Michael. Thank you for spotting that, and apologies to Yvonne for not picking that question up earlier. Also, thank you to Ailey. Apologies if I'm pronouncing your name wrong. For sharing from your group. It sounds like there's loads of interesting conversations there. I'm going to come to the question from Gavin. Nikki, I know we have one from you as well. I'm going to come to Gavin's first because you've answered the question, and then we'll come back to yours. So Gavin's question, that team you can see in the chat, is about the scale of the system that this is being applied to. In their breakout, they saw the approach being applied at the scale of frontline teams or thematic communities of systems, but were challenged by the scale of change needed to alter expectations, roles, supporting processes and functions if human learning systems applied at a whole system scale. Feel free to come in, Gavin, if you want to add anything to that.
You paraphrased that very well, thank you. I'm happy to clarify if helpful, but that, yeah.
So I think what we're trying to do is create something that the principles of which can be applied at any scale of change, but how you do each of those steps will be different depending on the scale of change that you're working in. So for example, you are always going to need, with any change, you're going to need an understand phase. But how you understand, who you talk to, the approaches that you take will be different if you are working on a really small change in one individual hospital ward, for example, versus if you are looking at bringing in a new digital solution for an entire health board. It's going to be really different. And so the digital librarian, I'm not sure if it's going to be a librarian. I don't know quite what the name is going to be of this thing yet. We're still developing that. But however, what that thing will enable people to do is to have support with picking, well, what's the right approach depending on the scale of change, depending on the type of change, depending on the system that they're working in. So it's different. So the idea is that the steps and the essentials are the same no matter what change you're working in, but the application of them will be different, and how you approach them will be different.
Yeah, and just to say, so around the name, which yeah, probably won't be, but just to say, we are drinking our own Kool-Aid. We are going through a period of understanding and engaging with people to understand what matters to them, so that what we ultimately call it will mean something to as many people as possible, and be inclusive of the number of people we want to use it. And in those tests, Gavin, and it's lovely to see you, Gavin. I haven't seen you in ages. Those tests that we're doing with the boards and health and social care partnerships, so some of them are doing them at their whole system level. The work that we did with North Lanarkshire was with the IJB and with the IJB board to understand, but did that bit that I was trying to explain, like connect from, so that it was change happening at the front line, which was some process improvements and PDSA cycles. There was, but as the board, they rethought how they did their governance and how they built that learning and quality management system through all layers of their system. Similarly, as we're embarking on the new sites with the boards, that getting them to understand that quality planning and thinking about engagement and how they do all of that right at the start of a big change process is part of the work of doing change. And they're really embracing that. So it gets, from the top to the front line. And as we said, there'll be different tools and different ways of thinking about it. And yes, we'll be building in that Cynefin thinking to help us understand and manage all of that. But we want to do it in a way that you can be a community organisation and engage with the Scottish approach to change, and it be meaningful for you, and you can be a board member and engage with the Scottish approach to change, and it help you to think about how you lead that kind of change across the whole board area.
Thanks, Diana. There's a couple of questions in the chat which we're going to have to leave for now. If any of you want to jump in and answer them, can, or we might be able to cover them later, from Ruth and from Nikki. We're going to take a break now until 11:35, 9 minutes. So have a quick stretch, get yourself a drink, come for a break, and we will come back together at 11:35. Welcome back, everyone. I'm sure if people aren't quite back, they'll be joining us shortly. So in the interest of time, we are now going to hear from Jo Matthews. And so I'm not going to say much more than that. I'm just going to hand over to you, Jo, if that's okay.
Hello there, good morning everybody. So as Vicky said, my name's Jo Matthews. I'm the Associate Director of Improvement and Safety here at Healthcare Improvement Scotland. And I'm delighted to be here this morning to share the work that we've been undertaking for many years, but more specifically in the last couple of years around how learning systems impact improvement at scale. But first of all, really, I just wanted to reflect with you around that place again in Scotland. And in my background on the screen here is where I live. It's a place called Linlithgow, which is the Royal Borough of Linlithgow. And you can see the palace in the background with the loch. And this is the birthplace of Mary Queen of Scots. So a very famous little town, which is absolutely beautiful. But I think it would be fair to say that I could say that it is the scenery that I absolutely love about Scotland. I could also say it's the culinary delights that our land produces on a regular basis, this being particularly one of them for me. But actually, it's about the people. It is the people that for me is where Scotland comes alive, the community, the welcome at any door, the humour, we call the patter, and the pride. And something we are very proud of within health and care and within the health and care system in Scotland is that commitment to the delivery of high quality, safe care. Sorry. Thank you. And as you've heard, a lot of the work that has been done across Scotland to increase that understanding and skills in quality improvement, what is recognised is that quality improvement is only one element of how we manage quality. And as Michael mentioned before, quality control, the improvement piece, our quality planning at every level of an organisation to enable that ongoing delivery of high quality, safe care is really key. And I suppose our quality management system is quite different to those within industry, where there can often be that very deterministic approach. We reflect those social relational aspects of health and care. I mean, those core components must be considered alongside people, culture and environment for systematic learning. And the central component of our quality management system that Michael shared earlier is that learning system, a system that collates and analyses a range of sources through the gathering of insights, makes sense of the intelligence from those sources through relevant networks, and identifies appropriate actions, translating the knowledge into practical support. And however, I think there is something that, when I mentioned earlier about the difference to our QMS to that of the industry approach, is the social piece, that cultural aspect of the change. And this description that places people at the centre, just like our networks at the centre of the learning system, reflects what we're aiming for. Placing people alongside those processes to enable learning on specific topics through the evaluation and reflective practice to assess what's working and what isn't, using qualitative and quantitative data, stories and insights, and through that developing mechanisms to aid decision making and turning that into action. And from a national perspective, which is the lens I'm reflecting through today, building those systems to identify where are those bright spots, but also where's the generalised learning to spread and accelerate those improvements. So SPSP probably reflects that very clearly with that shared purpose and common goal. And this approach has been at the centre of SPSP since its launch back in 2008. And for those on the call that maybe don't know what SPSP is, it's the Scottish Patient Safety Programme. It's the National Safety Quality Improvement Programme, and it aims to improve the safety and reliability of care and reduce harm. It's got three core elements: the essentials of safe care, an evidence-based package of guidance and support that was developed and co-designed by people right across health and care in Scotland to set out what are the clear areas of which we ensure for every person within every system every time is delivered and supports safe delivery of care. Alongside that, the improvement programmes themselves, and you can see there that spread across a whole range of healthcare, and we also connect into social care as well. And alongside that, the learning system, which underpins all of the activity that we do. And this really supports Scotland's ambition to deliver that highest quality care through a focus on safe, effective and person-centred care. Now, the method by which that we actually deliver that work has been collaboratives. And that has been through every aspect of the safety programme. And I'm sure there are many sitting on this call today who have participated within a collaborative at some point, have run or led collaboratives. But I think it's fair to say that we've had every variation of a collaborative, from the pure IHI breakthrough series model to learning networks through to very short sprints. All of them, however, have had in different forms a system for learning right at the centre. One in which there's been a local aspect for teams, and that could be right down to individual teams or at that local organisational level, to understand their own systems and processes and track the changes, through to those national mechanisms to bring local teams together to be able to share and learn. And if you've not already, and if you were about to embark on a collaborative, I would absolutely recommend looking at this publication from the This Institute, which highlights the key features, 5 key features of a high-performing improvement collaborative. And in particular, that area around mobilising leadership and building community, featuring highly within the publication, that aligns very closely to what our learning is after 16 years of delivery, where we've built a real body of evidence of what needs to be in place for impact. So I think any of you who have been part of those collaborative processes know that achieving sustained change and sustained improvement, and for in Scotland, the work that I lead around doing that at scale, has required collaboration at every level of the system. In effect, it really has been a nationwide team effort, evolving from a safety programme really into what we would say is a bit of a safety movement. And we know that the evidence says avoid going down those collaborative routes. It's blooming hard work, and it doesn't necessarily deliver the change at pace our systems often need. And I'm sure there's many on the call today who have felt like this at some point on your journey. But reflecting that there are some key points to enable collaboration to happen. That application of the quality improvement and a range of other methods to support that change, but through a model in which there are periods of being able to test, to track that learning, to be able to share that and explore what you need to change for the next iteration. But coupled with that, and that process needs to be a focus on people and relationships in order to build that learning system. Now, when we think about what we know about the relationships and we think about systems, Deming's system of profound knowledge describes 14 principles for continuous improvement, based on that understanding that the system is the sum of its parts, but the result of its interactions. It's all about the relationships. And the most important cultural characteristics of those safest systems is not that they have the right technical features in place, but rather that they're full of people, all at different levels, who have a sense of the change that is required and adapt in response to that ever-changing terrain. And in transforming those systems, ultimately about transforming relationships among people and building networks to shape those systems. Many otherwise well-intentioned change efforts fail because we're really not able or willing to embrace that we need relationships at the heart of that. Now, this is reinforced by work that Nicola Burgess produced through the Warwick Business School, exploring why people and relationships, and in particular the social networks that are created from these, impact on improvement. These pictures are the result of the network analysis that was undertaken in 2 organisations, undertaking the same interventions, making the same progress, but with very different outcomes. A reciprocal shared value within organisation A, fostering those interpersonal collaborations where everyone's talking about improvement, and then versus that organisational B where there's transactional eliteness and feeling excluded, just what Claire reflected earlier in her presentation. So when we're considering the context, that clear, concise, shared values, distributed leadership that fosters that interprofessional collaboration and that collective reflective talk, formal spaces for informal interaction. And I was really struck by how Nicola reflects on the social capital being more important than the human capital. So building our SPSP learning system has reflected all of those factors I've shared with you today and those different key features. Our learning system is made up of multiple parts and continues to grow and evolve as the work develops, from sources of information and tools and resources through to networks supported by a number of different platforms for people, all of which can be accessed through our website. And this learning system has supported the delivery of safety improvement work within our acute care settings. And that's what I'm going to focus specifically on this morning. Over the last 3 years, it is, the SPSP Acute Adult Collaborative has had a focus on reducing falls and falls with harm, alongside improving the recognition and response to deterioration. A huge amount of work has been undertaken across teams and services with the support of the collaborative. And I'm just going to reflect on one aspect of the work and how the learning system has resulted in sustained reduction in falls at scale. Now, this is the NES quality improvement journey, and it is something that we have used within all of our improvement work within Scotland. It provides a fantastic roadmap for any improver and enables you to plan and structure your improvement activities. The road to improvement for the falls work has most certainly not been linear. There's been detours, complete handbrake turns, and a number of roundabouts along the way for the teams, both locally and nationally. However, keeping that end destination in sight, being clear on the aim, and using the learning system as basically as the sat-nav to reset those paths as and when we have needed to. And this is the learning system in action. Addressing falls is one of the most common causes of harm for people in hospital, and it can leave a lasting impact for people, families, and the staff caring for them. And going right back to what his learning system looks like, reflecting on the approaches that we took through the gathering of insights. So working with all of the boards across Scotland, of which they use a measurement framework to collect their data alongside their improvement activity, sharing that through progress reports, coupled with the national team supporting them through coaching calls, site visits, a Teams channel of which people could connect across different organisations, and the participation within networks both within Scotland and the UK. Underpinned by those evidence-based guidelines, we're able to gather the insights and use that to sense make, to be able to understand what those enablers and barriers were, both locally, but also then what did we need to do nationally to support them in their changes. And a key aspect of what we were seeing through that sense making was how they were mapping those themes across the essentials of safe care, that first core element of the overarching programme, to be able to identify how the essentials could support in those improvements in addressing falls within their areas. And we used that to then translate that knowledge into action, to being able to spread the successful change through our learning sessions, both our webinars, our networks, and our in-person sessions. But also we used it to adapt the original theory of change through our Falls driver diagram and the supporting change package, which absolutely responded to what the learning was happening in a real-time basis. And we also published that through our impact report, which you'll be able to access through the links that we're sharing. Now, at the heart of that has had to be about how we support people in their learning. And in each stage along the way, creating those conditions and the environment in which that sharing of learning became daily business. And it's been really important being clear about why and for what purpose we were sharing that information and how it was being used. And that often has led to really being able to truly understand and treat vulnerability as a strength rather than a weakness, often at that leadership level. We don't know everything and we need to learn from each other. Being able to acknowledge that strength of vulnerability within leaders and their teams is something that both Professor Brené Brown in her TED Talks about the power of vulnerability, and the organisational behavioural scientist Amy Edson, who I'm sure many of you already are fully aware of, their approaches are great examples of the importance of vulnerability in leaders to create that psychological safety essential for organisations in striving to get to that high quality care. Because it's about that learning, and leaders, we must really admit that we don't know everything, and that actually it opens the doors for testing changes and for that learning. So it's through that learning system that we are now seeing the results that we are. The SPSP Acute Adult Collaborative has led to a 9% reduction nationally in falls in acute care in Scotland. And to have achieved that 9% reduction within acute settings during what has been one of the most challenging periods of service, I know both within Scotland, but I'm sure reflected across the whole of the UK, as a credit to all the teams who stuck with this process. We have 11 hospitals showing a sustained reduction between 9 and 28%. And if you want to find out more about what's actually how we went about that and the learning from that, you're able to access that impact report through the QR code. It reflects the key learning points that have resulted in the change, from understanding what is happening within teams in their local areas, being able to shift that culture from related to falls, which was one of risk and reduced mobility, to promoting and supporting safer mobility, and being able to embed the essentials of safe care through their improvement work. We do, however, know that it remains one of the key harms reported, and have heard loud and clear from cross-cutting systems. It remains an ongoing safety priority, and it will continue to be into the next phase of our acute collaborative work. Sorry, the buttons are very slow. So I just really wanted to wrap up by saying those learning systems are a central part of our approach to change, our improvement work, but rest really at the heart of our quality management system. But it can't happen without people and how we connect those people together in order that we can make the change. So thank you very much for your time this morning.
Thank you so much, Jo. That was great. I'm going to set you up in some breakout rooms again soon. I know there's a few questions in the chat and some of them are being answered, and that's great. And it might be that some of them are things that you want to reflect on in your rooms together now. We're going to give you, again, about 20 minutes, 15 to 20 minutes in your breakout rooms. I'm going to pop a couple more questions in the chat again. And so we wanted to invite you to share your reflections and your experiences in relation to learning systems, and also consider the question, how might we individually and or collectively influence effective local learning systems? So I think you might come onto some of the questions you were asking in the chat within that. I will, so I can see people kind of coming and going. So I'm doing some rapid moving about of people here between rooms so that hopefully you're not left on your own.
And if anyone would prefer to just stay in the main room to reflect quietly with your camera off, that's fine. You can just come back into the main room if you were thrown out into a breakout, or when it pops up and says join room, you can decline that. And then Vicky, we might have to do a little shuffle again later.
We may shuffle you around. So hopefully there are rooms where we are inviting at least 4 of you into a room. So hopefully that will mean no one is left on their own. But let's see. And as Gwenno said, you may want to kind of stay in the main room and do some quiet reflection on those questions. There's been a flurry of comments, so I think I might paste the questions again for you now. Okay, I'm going to open all the rooms and we'll give you about 17 minutes, I think. We'll come back together just before 12:15. So I'll open the rooms now and you should be able to click to join and just give us a shout if you've got any problems. Welcome back, everyone. Looking for Diana return. Welcome back, everybody. I hope that was a good discussion. In the breakout rooms box, I could see lots of microphones going up and down really fast, so it looked like you were having very animated, productive discussion. So I hope that was useful to have that reflection and sharing time. Again, if you want to share anything in the chat, please do. I'm going to hand over to Diana and Jo now to invite some reflections from you and to offer some key takeaways of their own. Gwenno, do we have slides?
Yes, I can share the link to Slido if now's the right time, Diana and Jo. Yeah.
Bring up the slides.
Hi. So what Jo and I will have had some thoughts that the things that we'd really like you to take away from today, but actually what we'd really like to hear is what the 3 most important things you've taken away today. So as we're trying to shape our thinking and learning in this area, it'd be really insightful for us to hear what really mattered to you from today. So there's a Slido poll there. You can scan the QR code. You can join the app on your phone using the hashtag 8230129. I feel like I'm at the end of Strictly here. There are terms and conditions. Don't vote until the last dance has ended. Anyway, yes, please, we'll give you a few minutes just to type in. I can see 6 people are enthusiastically typing. But yeah, if you can get onto Slido. If you can't get onto Slido, if you're really stuck, then the chat is still available. If you want to put them in the chat, we can pick them up from there as well.
And we hope you had some really interesting discussions, which we'll be keen to hear more about through your takeaway messages. As part of our sharing of slides and the resources following this morning's session, the output from this Slido will also be included within that, so that you can see the learning that you have generated yourselves through your discussions.
wonder, has anybody done a TikTok ASMR for Slido? I'm finding this very calming. You know, there's all these TikToks you can now watch people cut grass and wash cars.
Can't say it's doing it for me, Diana, but I mean, I'm glad you're happy. So.
Thanks, Gavin.
It's somewhat reassuring, though, what we're seeing coming through. It absolutely resonates with our experiences in supporting the work. Yeah, I think probably, I can see there's still 5. We're just down now. Probably we're probably coming to the end, and thank you very much for people for adding your thoughts and reflections. As soon as that's completed, we'll make sure that it will be saved. But I'm wondering whether you want to move to the next slide so that we can.
Great. And if you just move to the next one, please, Gweno. So these are in thinking about this Q visit, which we've been thinking about for a long time, and also thinking about all the discussions we've had about quality management systems and the Scottish approach to change and human learning systems. I think that the things that struck me is that learning is often seen as a nice thing to do on the side. It is seen as a thing that, you know, you go into sessions to do learning, but actually it is the rigor. It is the rigor of doing it. What you know, the human learning systems evidence talks about is that it is part of your governance and management. What within patient safety programs, what Joe describes is that learning isn't a thing that you do your patient safety work and then you go off and have learning sessions on the side, is that it is really the rigor at the heart, and to not recognize that it is a critical part of our management structure is how we do that learning. It means that we will just continue down the same route that and trajectory we're on into ever increasingly unsafe and overstretched services. Which sort of leads me to the second one, which was I sort of woke up early in the morning and was like, the challenge is if we learn, and there's a whole raft of evidence written about the difference between doing evidence and evaluation and learning that stays on a shelf and doing it with implementation in mind. So what the quality management system does and the Scottish approach to change does is gives you structure for how you take that learning into implementation, how that learning at the heart has to be taken into action, and a key part of our work is around that knowledge mobilization. So learning, so essentially if you're just going into these groups and you're having a lovely time, even here today, and you're having a lovely time learning from what we've shared today, and you don't do anything with it, it's just a hobby. It's gorgeous. I love having a hockey. I play hockey now, thanks to Jo Matthews. I'll blame her entirely, and end up regularly bruised. But that's my hobby. Learning at the heart of work should needs to be taken into implementation. And the last one is really what we've been trying to embed throughout the work. You'll see it's on the co-production and co-design around the QMS. It is in every stage and in every essence of the Scottish approach to change, and it breathes through human learning systems and human factors and all of those different disciplines. Is learning with people throughout the process is what's transformational. For those who are interested in the human learning system stuff, the first story I heard was that people learned that the reason people were in debt with the council was because they didn't have money, and they were sending bailiffs in to people who had no money. It wasn't I wouldn't pay, it was I couldn't pay. And they learnt with them that actually they needed support to change their lives, to thrive, and then they would pay. That is transformational. Learning with our within our acute systems, learning within our community systems, learning from people that we poorly serve. That is how you transform an overflowing A&E to somewhere that has community enablement hubs that support people with addiction and mental health crisis. So that learning with people through every single step of that journey in a way that really touches on inequalities, really recognises that you are learning with staff, with patients, with families, with people who need services, with local communities in a meaningful way together as an equal. That is what will really transform the health and social care that to hopefully be something that is equitable and sustainable going forward. Jo, any final words from you?
No, I think you've covered it beautifully. I think the key piece that we have learned through that learning is you're continually learning. This is not something with a start and a stop, and through these processes we continually adapt and respond to the changes, the learning that we gain through supporting the teams right across health and care. And we wouldn't be able to do that without the rigour, without the process, and without the people.
Thank you. Vicky, back to you.
Thank you, Diana and Jo, and you'll see in the chat lots of appreciation for those messages and lots resonating for people. So thank you so much, and thank you to all of the team. So also to Michael and Claire, and as I mentioned in the background earlier, and some of you will have met them in breakout rooms, David and Elizabeth as well. All of you for making this visit happen and for all of the rich information you have brought to us today, and for being generous to sharing your contact details as well. What we'll do afterwards is that we'll share the recording, the slides. We will also share some follow-up links. Some of them you will have already received in the welcome pack. We'll repeat those and add to them. There's been some great contributions in the chat, both from the Healthcare Improvement Scotland team, as well as some of you participating. So thank you all for participating so fully in the discussions and in the chat. Gwenno and I will go through that, and we will pull out any of the kind of links that have been shared, and we'll add those to a set of follow-up resources that will be emailed to you in the chat and now on the screen as well. You'll see we are keen to do our own learning and improvement about how these visits work. The Health Foundation are very appreciative of any feedback that you can give. We'll also share feedback with hosts. So we'd be grateful if you could spend a few minutes filling out that survey either now or later. We will share it as part of the follow-up as well. So I think that's about all I need to say. And also thinking back to Katie's messages earlier, if anybody wants to learn more about Q membership, please reach out to Katie. I think Matthew is on the call as well. And we'll reshare the link of how you can join the Q community afterwards as well. You can also look on the website for upcoming events. So thank you so much again for the Healthcare Improvement Scotland team and all of the work that you've put into this visit. Thank you all for coming and for all of your contributions. We'll stay on now. We'll pause recording and we'll stay around in case anybody wants to say hello in the last few minutes. Thank you for a great visit.
Thank you very much.